on the door and you wash your hands. You say, hi, my name's Professor Michael Baez. I'm gonna do your assessment. I'm looking at her hands, I'm feeling her skin. I see her skin's warm and dry. I don't see any tattoos right here. I can do cap refill also on this one side and see that it's less than 2 seconds, so that's normal. The reason I'm holding her hand and looking at her wrist is because I'm checking her orientation. What's your name? Okay. And do you know where you're at? You do? Okay. Could you tell me? All right. And who's the, do you know what day it is today? Okay. All right. And so I see that her speech is clear and appropriate and that she turned her head and tracked me and talked to me. So that's part of her cranial nerves also, but I'm still going to check him. But I'm already looking at her orientation. I see that her affect is pleasant and appropriate for a patient in the hospital. I'm putting her bed to my hip level, and then I'm going to raise her in high Fowlers. Ma'am, today I'm going to do a physical assessment on you. Is that, I've already done the vital signs. The vital signs are what was on the sim, and so I appropriately addressed if there was any problems. All right. Now, if we tell you she's really short of breath, and we give you a pulse ox of 88, before you start talking, what are you going to do? Raise the head of the bed. Why are you way over there?
Because I need table right.
Okay, you can move my paper.
Okay. I can see though. We're good.
All right. I don't want anyone to feel left out. All right. So if she's really short of breath, or we give her really low blood pressure, then we expect you to know to do this. To keep her flat and raise her legs, right? Okay, but since we didn't do the sim, we're just gonna raise her up like she's okay. But I just want everyone to know that. So from now on, boot camp, when you come back after your 2-week break, if we give you someone really short of breath, the first thing you do before you do your physical assessment is always deal with the vital sign or the pulse ox that's really abnormal, okay? Either raising their legs or putting them in high Fowlers. Okay, normally I wouldn't do that, I would call for help. But I want her so you guys can see. All right, so I've checked, so she appropriately told me her name. And now, what's your date of birth? Oh, I know, I'm sorry. Okay, and her date of birth is correct. So she's awake, alert, and orientated times 3. I know that. Her speech is clear and appropriate. Like I've already told you, her affect is pleasant and appropriate for a hospitalized patient. I see that her hair is well made and coffered. There's not a mess. I don't see any lice or bugs or any drainage or bumps or anything abnormal. I look at her ears are symmetrical. There's no piercings. There's no drainage from the inside of her ear. If there was clear drainage or yellowish drainage, I would check it on a 4x4 to see if it did a circle, a halo. If it did a circle, then I'd know it was cerebral spinal fluid. Okay, so that's why I'm checking always for drainage. All right, her eyes are tracking me. Like I said, I see that her pupils are both equal, even though I'm not doing that part yet. I can see that because of the light in the room. I see that her nose is symmetrical. There's no drainage coming from her nose. Her smile is appropriate and her teeth are intact. Okay. So now I'm gonna ask her if she's had any change of her smell in the last 2 weeks. Okay, you haven't. Then I would tell her that the olfactory is intact since I don't have any coffee or lemons in my pocket. So now I'm going to chat the rest of the cranial nerves. I'm going to do optic, oculomotor, trochlear, and abducens now. So first I'm going to do her peripheral vision, and so I go like this, and I ask her when she sees my fingers. I can also have her cover her one eye and go like this, okay? I'm going to do confrontation, and I'm asking her to follow my pen light without moving her head as she goes in. What I'm looking for is that her eyes move both in, that there's no nystagmus, and that her pupils appropriately constrict. So I'm seeing all the time that her pupils are constricting equally. Now I'm going to do the 6 cardinal directions. I ask her to not move her head and to just follow my pen light with her eyes. I go up, I come down. What I'm looking for is again nystagmus. Do I see that one eye can't track? I come down, I come up. It's important to always come in the middle to see that nystagmus. If you go like that, you don't see it. So then I go right or left, it doesn't matter. I come to the middle. I go to the other side, I come to the middle, then I go to 2 o'clock, or you could start at 11, come to the middle, you come to 7 o'clock, you come to the middle, you come to 11 o'clock, you come to the middle, and you come to about 5 o'clock, and you come to the middle. So now I know her cranial nerves, her cardinal directions are intact. So now I'm going to turn on my pen light. I'm going to see if her pupils constrict. Her pupils are a 4-4 right now because there is a lot of light in the room. When I put my pen light in, I see that they constrict to a 2-2. So I would write 4-4, arrow 2-2. So that means her pupils are equal, round, reactive to light accommodation without me, and then that I can now say that. Okay, so since I'm here at the head, and even though it's part of the vessels, I want to just kind of do it organized, so I know it's a little out of order, but I'm going to palpate one carotid artery. She's a 3+, which is normal for a carotid. She's a 3+ here. If she would, if I felt anything funny, I would go ahead and turn the bell side of my stethoscope and listen with it. There's 3 distinct areas: the angle of the jaw, the mid-neck, and then the clavicular on each side. This is the only vessel test that you do separately, not together, because you would cut off oxygen to the brain. So now that I'm there. Oh God. So now I'm done with her neck, and I could also ask her to swallow for me since I'm here, right? Even though it's part of her cranial nerve, glossopharyngeal, sorry. So I could ask her to swallow, and now I'm looking at her respiratories. I see that her respirations are labored and even. I see that her chest movement is symmetrical. I don't see any chest heaving. She's not in any distress. She's not tripoding. She's not, if she was younger, I would expect nasal flaring issues and respiratory distress. She's not using accessory muscles. So I know that her chest movement is symmetrical. So I know her respirations are fine now. So now I can continue with my assessment. I'm gonna listen right here. I ask her to take a slow, deep breath through her nose, and then slowly exhale with her mouth. I ask her to do that again. Then I'm gonna sit her up. I'm gonna listen. Don't do that. It's not yoga class. So now you're gonna go, it doesn't matter if you go ladder, okay, or you go Z. I like Z. So I go 1, 2, 3, 4, 5, 6, and then right is midline. Well, that was my left arm, sorry. Right is midline, is mid, because that's her mid lobe. That right is the only one that has 3 lobes. That's 7. Bases are 8 and 9. Oh my God, if that happens in your physical assessment, stop immediately and call a code. Okay. So now I'm gonna tell her that her respirations are already fine, her lung sounds are clear. I don't hear any crackles or wheezing, and so now I'm gonna just lower her gown a little bit so that I can see her where I'm gonna auscultate her heart. So now I listen to her second inner space, right sternal border, and that's her aortic. I listen to her left or second intercostal space, left sternal border, to her pulmonic. I think if you look at your thing, you're not responsible for herbs. So you can just go straight to tricuspid, which according to Jarvis is left lower sternal border or lower left sternal border. I don't know how they word it. Either left lower sternal border or lower left sternal border, however you remember it. I was taught fifth inner space, so if you say that, that's okay. So you listen there for tricuspid, just as a heads up. If in clinical they tell you they have a tricuspid like murmur or something, you can't hear it. Just like how mitral, I told you to lean her to the left to listen to the mitral, it pops it. Well, the tricuspid, if you lean them a little to the right, it'll pop it. If you can't hear the sound that they say is abnormal. And then for her mitral, which is also her apical and her PMI, I go to her mid-clavicular line, fifth intercostal space. If I always use the tip of my stethoscope to move it if there's something in the way. If it's pendulous, then I go ahead and I use the back of my hand only. I don't use my hand, okay? And so I listen. Now I can go ahead, I've heard her heart, and there's 3 positions you should listen to her heart in. That'd be her left side, high Fowler's like I just listened to, and supine. And you listen to all 4 valves, both with your diaphragm and your bell. But for check off, we just want you to say it. We want to make sure you know, okay? All right, so now I've listened to her heart, so now I can do vessels. So I've already done her carotids. I told you they were 3+. I now listen to her brachial. Her brachial is 2+. I'm palpating them together. I feel her radial. Her radial pulses are 2+. That's normal. They're strong and regular. If they were irregular, I would immediately stop and palpate that for a minute, and then I would listen to the apical pulse for a minute. I'm going to go ahead and just show you where I would listen to her femoral. I'm going to go ahead and lay you down, ma'am. So you would palpate the femorals together right here, okay? You palpate the popliteal together, but these are often not palpated but you're not worried. As long as you can palpate the feet, the pedal pulses, then you know the entire leg has good circulation. So I go ahead and I palpate the dorsalis, or the posterior tibialis, excuse me. And then I do the dorsalis pedis. And I check her cap refill since I'm down here. I'm looking, and it's less than 2 seconds. You wash your hands because you touched her feet. So now I'm going to do her abdomen. So I'm going to cover her up with her sheet and tuck it underneath if she's wearing underwear, which most people do nowadays. Very few people are commando, unless you make them. And usually we only make you if you're going to surgery. Then you got to go commando. So you're tucked underneath her underwear, and then you just lift to this. So with her, if you stupidly pick her, you got to start naming what you see now, right? So now I see that she's status post the right chest tube, because I see a dressing where a chest tube would have gone. I see that she has looks like an ileostomy. So my drainage, I expect to be loose green drainage all the time. It's not C. diff. It's loose and green all the time. It always happens. So in other words, the drainage never stops. It's not like a colostomy where when they have colostomies, it's like pooping, right? They have times. You can time it. Okay, the ileum is forever, okay? So now I see that, and so I go ahead and I look at her abdomen. I would call her abdomen round. She doesn't have any stria. She doesn't have any scarring. She has a weird umbilicus, but oh well. So now I'm going to go ahead. I inspected. I'm going to go ahead and auscultate. So I auscultate with my diaphragm. I listen in a clockwise manner from the right lower. I listen here, I listen here, I listen here, and I listen here. I turn my stethoscope to my bowel to listen to see if she has an aortic aneurysm. Okay, there's also other arteries you can listen to with your bowel, the femoral, the iliac, and the renals. Okay. However, I'm not going to do that. So now that I've auscultated, I'm going to go ahead and percuss. So I go like this. I expect hollow, but now here I expect dull. I expect dull because of the pancreas, gallbladder, and liver, mostly the liver. I come here, hollow. If I hear this sound here, I'm scared because that means they have splenomegaly. So now I listen here, and that's hollow, okay? Now I go ahead and lightly palpate, okay? If she came in with complaints of urinary problems, I would go ahead and sit her up and do her CVA. God. Like I said, what the hell is you really going to? And if she had, I forgot what I was going to say because that the CVA. Okay, yeah. So you would do CVA if she came in with any urinary problems. If she had CHF, you'd do hepatojugular press. You'd ask her to take a deep inhale and press in to see what her JVD did. Okay, that's if she had CHF or bad pulmonary edema. Okay, so you've lightly palpated now. You would also ask about her GI. When was her last bowel movement? What does her urine looks like? But obviously she's not having bowel movements. That's why I say don't pick the mannequin. Pick someone healthy. So you're not having to mention all this stuff. Okay, so now I've done the physical assessment that I can do on my bed, I would go ahead and sit her up. I would ask her if she gets dizzy before I stand her up. Then I'm gonna tandem walk her. The reason I tandem walk her with me holding my partner's hip like this and walking like this is because I don't know if she her gait is strong and steady yet. Now that I know her gait is strong and steady, I can go ahead and ask her to do the Romberg, ask her to do heel to toe. And then ask her to do, I think that's all I have on there. What?
You want to do the calf one?
Oh yeah, you could ask her to
Heel
do
to toe.
toe to chin, or shin to heel. I don't know why they call that shin to heel. I guess because you're supposed to go like that. And then, and I did it on purpose. I purposely forgot the cranial nerves. That might happen, you're stressed. So you just say, oh my gosh, I forgot my cranial nerves. So I'm asking her to sit back down so I can finish my cranial nerves. That's gonna happen. You're gonna forget stuff. I've had people forget the cardiac, the whole heart. You would think you wouldn't, but you're a little stressed that day. Especially if Dr. D's watching you. And that's gonna happen, so just, can't always be me. Okay, so I did the eyes, right? The ocular motor, the trochlear, and the abducens. And I'm gonna do trigeminal, so I can ask her to smile. I can ask her to raise her eyebrows. I ask her to close her eyes, and if she feels this. Okay, I see that everything's symmetrical, so that's intact. So now I'm gonna do facial. And so now I ask her to grr, and I ask her to, close your eyes real tight, and raise your eyebrows a lot. Okay, she does that. She's been hearing me fine, so I know her acoustic is intact. So because I know her acoustic's intact, I go ahead and say to you that if I was gonna start a drug that might cause hearing loss, like gentamicin, or if I was worried about her hearing, I would do the Rhine and Weber test, which is with a tuning fork. So I've already tested her hypoglosssia by having her swallow. Now I do her vagus. I ask her to say ah. Okay, oops, wrong way. So uvula is midline. Now I ask her to do spinal accessories, which is also part of her muscles, right? So I ask her to press my hand. If you notice, I'm using the back of my hand, not like this. And then I ask her to raise her shoulders up. Then I do the glossopharyngeal by having her stick out her tongue and go in the 4 directions, cardinal directions: north, up, down, left, right. And that's the that's the cranial nerves. And so I ask her, I'm done with your physical assessment. Do you have any questions about it? No, your head shouldn't fall off like that. You're right. That is an issue. I'll call the surgeon as soon as I can. So you make sure she's comfortable. Then you put her down. That's important. You don't leave we call that, when nurses leave them in that high range, we call that ortho height. You know why? Because if you leave them like that, they're going to end up in the ortho floor, because when they fall and crack their hip, that's where they go. Okay? So, and then you recover her back up. Any
What about
questions?
the musculoskeletal?
Well, we did. Oh, yeah. I forgot that. But We did the head and the shoulders, so then you can do grips. And you did musculoskeletal by having her walk and do stuff. So I know her feet are fine, but if you wanted to be intact, you could do that. But really, once you have them walk, that kind of covers everything except for the grips. That's the only thing I forgot. So thank you, Roy. I did forget the grips. But once they walk, you have them walk, and you can say, you know, you walk with your partner, right? And they're, of course, their gait's strong and steady. Okay, and then you say their gait's strong and steady. Then you can say, I know their bottom muscles are intact, that they're good. So now I'm gonna test their balance and some other things. Any other questions? You look like you have a question.
No, I don't.
Okay. Okay, go practice.